Professor Gaffar is the professor in Durban Medicine School. Is now the past president of the president of South African Thoracic Society. The past. It is the past president. It is an expert of the phenotype of COPD.
Don't know. We'll know after the questions. Thank you very much. I'd like to thank the organizers for again inviting me to share what's current literature in COPD or BPCO. I'd like to propose something very controversial, and I think I'll also present some literature to support that. We must get over saying asthma, BPCO, ACOS, and call it chronic airways disease with different attributes. Then there'll be less controversy, more research, and more precision medicine. I'm sure Fan is going to comment on that. Okay, the problem we have at the moment is that the COPD guidelines create an oversimplification, and they present an attitude of one size fits all. In other words, we have patients put into different groups, and all the patients in each group are treated the same. And if you look at the 1995 ATS statement for the management of COPD, I think there was some progress there, and we've retrogressed since then. And the progress was that we had some phenotypes of airways, obstructive airways disease, and that was chronic bronchitis, emphysema, asthma, and the overlap. And this was obviously stated a long time ago, but we've moved on from there. I'd like to remind you that COPD is a very complex disease. It includes many elements, and at the same time, it's heterogeneous. In other words, if you look at each patient, you may not have the same elements in every patient, and therefore it makes the disease more complex in that sense. The actual disease is complex, and each patient is very different to the next one. And that's why I'm saying you need to individualize the treatment in different patients. How do you do that? You need to identify the elements present in each patient, in other words, these elements, and then direct your medicine to those elements. Exactly what Fan was saying for asthma. And he used the term precision medicine, which I totally agree with. I think we've lost the projector.
Please. Hello. Il y a un problème.
Okay, so what is a phenotype? Very simply is what can be observed, in other words, what can be seen, and this would include clinical, functional, imaging, meaning X-rays, CT scans, etc., and or biological features, which is what Fan was showing in the earlier talk. And therefore this depends entirely on the assessment performed. In other words, it's the eye of the beholder, and I've got this from Alva Augusti's review on phenotypes. So the phenotype can be defined by basically what you're looking for, all right? So that's important to understand. And the endotype refers to the cellular and molecular pathways involved in the pathogenesis of the disease. So just looking for cellular and molecular pathways is not enough. You have to show that it is involved in the pathophysiology of the disease, and that's what we call endotype. Okay, now the last COPD guideline used a combined assessment of FEV1, symptoms, and exacerbations, and then proposed 4 phenotypes, A, B, C, and D. And that guideline then proposed treatment for each of these 4 phenotypes. and some of these treatments are not supported by good clinical data. I think we're all aware of that, and it's based on expert opinion. But these treatments do not address the biological mechanism in each phenotype. And as you know, a phenotype may be due to more than one biological mechanism. And that is why not all patients respond equally to all the drugs. We need to be able to identify responders. And that's another, oops. Okay, so we need to be able to identify the responders to the treatment. So how do you decide on that? So you've got to choose what criteria you use to assess response. And if you look at the current COPD guidelines, it's silent on how to assess response to treatment. Okay, it basically tells us how to assess severity, how to put them into those categories, start treatment, and then what? We see patients who come back to us and say, you've been on treatment, doctor, but I'm not feeling much better, I'm still short of breath. Patients are not interested in exacerbations because they have 1 or 2 per year. They're more interested in what they can do without getting short of breath. Okay. So the first study I'd like to just briefly summarize is the famous COPD gene study, which is ongoing, and it's giving us interesting data on genetic analysis, CT scan findings, biomarkers. And this is an ongoing study and has produced very valuable data and indications on how further research should be directed. The ECLIPSE study, I think all of you are familiar with, evaluation of COPD longitudinally to identify surrogate endpoints, predictive surrogate endpoints. It's a 3-year observational study. It clearly demonstrated that COPD is very heterogeneous, discovered some biomarkers which are still to be put into practical use, and identified the frequent exacerbator phenotype as being an important phenotype to address treatment more aggressively. Also, the study identified the rapid versus slow decliners in FEV1, meaning not all patients lose lung function in the same trajectory. Some lose faster than others, and we need to be able to identify these patients and address our treatment to that to try and slow down this rapid decline. And also identified a COPD phenotype with systemic inflammation. I caught some of the discussion earlier on eosinophils and what level to use in your severe asthma. But remember, you also see eosinophils in some COPD patients, not some, a lot, quite a significant proportion in patients with ACOS. Even COPD patients who don't have ACOS, there are many of them who have a high eosinophil count. So where do you place those patients? How do you address that eosinophilic inflammation? And a very interesting study, which I'm sure a lot of you are aware of, is the SPIROMICS study. And I listened to Chris Cooper presented recently at CHEST, and he said, he presented the study which looked at symptomatic current or former smokers with normal lung function. Okay, so these are the patients who are not in our guidelines. So you've got patients who have normal lung function, who are previous or current smokers who are very symptomatic, and compare them to asymptomatic current or former smokers and non-smokers, and grade 1 COPD. And they looked at exacerbations and found that these patients who had normal lung function, in other words, they're not COPD by definition, had far more exacerbations, and similar to your grade 1 COPD patients, or in fact more. They had significant activity limitations. They also had evidence of airway disease on the CT scan. And that's interesting. We tend to ignore these patients. Patients who come to us, we say, yes, your lung function's fine, go away. When your lung function drops, I'll treat you. Or when you get an abnormal ratio, your FEV1, FVC ratio, if it drops below a certain level, then I'll treat. So our guidelines are lacking in this. How do you address these patients where you now have got clear data to show that they're at risk of exacerbations, their quality of life is impaired, and they have more dyspnea. And many of these patients actually are using treatment already on their own. They use inhalers, and they don't, it's not recommended that we should give them inhalers, but they find relief with the inhalers. So that needs to be addressed as well. And this looks, basically, I'll just show you some of the slides from that SPIROMICS study, which was published in the NEJM. And just as an overview, we know COPD diagnosis rests on chronic symptoms and airflow obstruction, but many patients have chronic COPD symptoms but no obstruction, and this study looked at those patients. And you can see this here, respiratory symptoms in patients. These are controls who never smoked. These are current or former smokers with preserved lung function, meaning they have a normal ratio and a normal FVC and FEV1. And then current or former smokers with mild to moderate COPD. And you can see this falls in between, so they're not normal. Okay, although they have normal spirometry, they have abnormalities on the symptom score, and the risk of respiratory exacerbations is also higher in this group of patients. So normal by definition, but they have increased symptoms, increased exacerbations. And then the effect on exacerbation rates on different, they then categorize them using different FEV1, FVC cutoffs, but it still remains significant. Okay, I'm sure you can't read this, so I'll skip that. And then the risk of exacerbations with the CAT score. The CAT score was used to actually quantify their symptoms of 10 or more as compared with a CAT score of less than 10. And this showed a significance in the relative risk of exacerbations in these patients with a CAT score of more than 10 compared to less than 10. So in the SPIROMICS study, although they did not meet the current criteria for COPD, the symptomatic current or former smokers with preserved lung function have exacerbations, they have activity limitation, and evidence of airway disease. And they also use a range of medication without any evidence base. So, what are the relevant clinical phenotypes in COPD? Hyperinflation phenotype, or the emphysema phenotype, chronic bronchitis. We know that emphysema is not accepted as a phenotype clinically because it's a definition on pathology, on histology. Okay? Chronic bronchitis can be used as a phenotype. The overlap syndrome, the phenotype of the frequent exacerbator. And what about the fast decliner? Okay? Should we call that a separate phenotype? In other words, greater than average decline in FEV1. And these patients need closer monitoring of the spirometry for at least 3 years. But at this stage, we don't have any specific treatment that's been shown to be effective in large-scale clinical trials that reduces FEV1 decline. What about the inflammatory phenotype? In other words, patients with elevated serum levels of inflammatory markers, they have been shown to have a poorer clinical outcome. We still don't have yet any specific treatment to address, and here I'm talking about things like CRP, etc. Should current smokers, patients who have COPD and continue to smoke, be regarded as a different phenotype? And lastly, systemic, meaning patients who have significant comorbidities like cardiac, diabetes, osteoporosis, weight loss, etc. I think the bottom line there is for both of these, we would address firstly the smoking in its own right, and here we would address the concurrent disease in its own right as well. Okay, this is a recommendation by the Spanish guidelines, okay, and they call it case EPOC, and they divide COPD into 4 phenotypes. Either a phenotype of an infrequent exacerbator who has either chronic bronchitis or emphysema, the overlap patient, a patient who is a frequent exacerbator with predominant emphysema, and a frequent exacerbator with predominant chronic bronchitis. And this is what their guidelines suggest at this stage. And they then tailor the treatment according to that. So all patients will get long-acting bronchodilators, whether you have no exacerbation but are symptomatic, the overlap syndrome, exacerbated with emphysema and exacerbated with chronic bronchitis. But obviously, the overlap syndrome would get inhaled corticosteroids as part of the basic treatment. Patient who is exacerbating but does not have emphysema, one could then add a mucolytic because, I think this is a bit, we could discuss this, where the use of mucolytics, there is some data to support that. And the ones with chronic bronchitis, we could add on to the LABA, ICS, a PDE4 inhibitor, and if that doesn't work, the macrolides. But I think what people are beginning to realize is that not all exacerbations are the same. You may have some that are eosinophilic, some that are neutrophilic. You may have some that are due to bacterial overgrowth. So each one of those will have to be quantified and addressed differently, instead of putting all of them onto one of these drugs. Okay, I took this article from Dave Singh and others on current controversies, and I think he makes some interesting points on the relevance of phenotypes and endotypes, and is FEV1 a useful guide for treatment? Again, those of you who have seen the new guidelines that was released about 10 days ago, the GOLD guidelines, will understand where it's actually come from, because these guys are all part of the GOLD committee. And what these people recommend in this perspective published in the Blue Journal is that we should do away with using FEV1 in terms of deciding what treatment to use. Because if you look at the C and D, if you look at that above the line, it could be due to either deteriorating lung function or exacerbations, increase in exacerbations. And sometimes the two don't tally. And we know that FEV1 does not correlate very well with symptoms, and also it does not necessarily correlate with frequency of exacerbations. At the moment we use a cutoff of 50% FEV1 to say patients with less than 50% are more likely to exacerbate. But if you look at ECLIPSE and you look at some of the other data, patients with FEV1s of 50 to 80% also have a significant history of exacerbations. So in terms of deciding on future treatment, and current GOLD guidelines have actually adopted this approach now, where we don't use FEV1 to decide on C and D, all right? We just use a history of exacerbations and then decide should that patient go on to more aggressive treatment. But I would suggest one step further is to then phenotype that patient to decide what type of exacerbation he has. This is not doing away with FEV1 in terms of diagnosis and assessing severity and response to treatment. You can still use it. Use the change in FEV1 to assess response to treatment or progression of the disease. In terms of diagnosis, you do need spirometry still to confirm the diagnosis. But to decide on pharmacological treatment, you don't need the FEV1, and that's the new thinking at the moment. However, if you're deciding on surgical treatment like lung volume reduction, etc., then you would fall back onto spirometric values. And then what biomarkers have been proposed: fibrinogen, club cell protein 16, SRAGE, and then markers of persistent systemic inflammation, sputum eosinophils and blood eosinophils, which are probably, blood eosinophils is probably more practical. The higher levels of blood eosinophils correlate better with the response to ICS, and they also have higher exacerbations with inhaled corticosteroid withdrawal. And like the discussion earlier on, what level do you use of eosinophils as a cutoff? 2% has been suggested. Higher than 2% are the ones that are more likely to respond to ICS. But some workers believe you should be using an absolute value, okay? And value is range from either 200, 350, etc. Okay? So that's still in a state of flux. Okay, and this is what summarizes our approach. Historically, we used firstly GOLD 1, 2, 3, 4, and we used FEV1 to guide treatment, and then GOLD, A, B, C, D, and clinical phenotyping. But in the future, hopefully, we'll be looking at what we call treatable traits and endotype biomarkers and disease activity markers. And you know the Dutch hypothesis that asthma and COPD are a continuum, or they represent the extremes of this continuum of disease. The confusion we've caused is we stuck on using lung function tests to confirm or exclude one or the other. And I think we need to move away from that. Then the non-smoking COPD, is it really COPD? Okay, and I believe it's not, and I think we need to actually, have more data to that end. And Augusti, in his very erudite paper, presents this concept of treatable traits. In other words, do away with COPD, asthma, ACOS, etc., and rather identify a patient as whether he has airway disease or not. Okay, and his approach is using your history, clinical examination, and risk factors, then performing spirometry, exhale nitric oxide blood eosinophils, and looking at all of that data together with the history. Okay, so if they have a strong history or risk factors present or abnormal test results, they have a high probability of airway disease. If they don't, then they have a low probability of airway disease, and those patients are then managed as non-airway treatable traits. So if you follow this and you confirm that this patient has got a high probability of airway disease, in other words, he's not using the terms asthma, COPD, etc., you would then identify what he calls treatable traits, okay? And that would be either a pulmonary, extrapulmonary, or systemic. And extrapulmonary, I'll come to the last one now. The pulmonary, he looks at various things like airflow limitation, including what I've listed, yes, smooth muscle contraction, you treat that trait. Loss of elastic recoil, you treat that trait separately. Airway, mucosal edema. There's not enough time to go into each one of these in detail, but I suggest you look at this this article. It is very interesting reading. And and then he looked at eosinophilic airway inflammation. If it's high, anti-inflammatory in the form of inhaled corticosteroids, chronic bronchitis, bacterial colonization, rather go for antibiotics, etc. All right, so he lists all the different treatable traits, and one could shorten or expand this list. And he also looks at extrapulmonary treatable traits of airway disease, deconditioning, obesity, etc. And then behavioral, lifestyle, and risk factors modification. So should we abandon the terms of asthma and COPD? I don't think so. I don't think it's prime time yet for that, and that's what he states, and I agree with that. We need a lot more data. But I think this sounds like a very pragmatic approach. Looking at the kind of patients I see in my practice, and I don't know if Umesh will agree, and I'm sure a lot of you in the room will agree, sometimes it's very difficult, and we use the whole Oslerian, Osler's principles. We say, this patient, we put him in that box, that one in that box, and the other one in that box, and therefore, based on the guidelines, I'll give this one this treatment, that one that treatment, and so on. And I think it's time to change our thinking and rather look at endotypes, phenotypes, and say this patient has got chronic airway disease with this predominant biomarker, etc., and address treatment according to that. At this stage, we don't have enough treatment options to tailor to each one of those. So we're still a bit stifled, but hopefully in the future, we will have that. So I hope I've given you some food for thought, that everything is not that meets the eye. These are not all minions. I assure you some of them are wearing masks. But I'd like to end there. Thank you.